Hi guys, welcome back. We shall now be talking about diseases of the neuromuscular junction, and first on the agenda would be aspects related to myasthenia gravis, which is an example of type 2 hypersensitivity reaction. Well, it's an autoimmune disorder which will be having a waxing and a waning course. It will have exacerbations, and especially in pregnancy or infection, they could even be worsening to a level that person might require ventilatory support. That's called as myasthenic crisis. You will notice that in some books it is mentioned as type 5 hypersensitivity reaction. So I would like to put it on record like this. If the options are between 1, 2, 3, 4, then answer is type 2. But if the options are like 1, 2, 3, and 5, then answer it as type 5 hypersensitivity reaction. Now, what's the basic problem in this condition? The receptors for acetylcholine are the ones which are affected. It's a post-junctional defect. Traditionally, acetylcholine will act on its receptor, which will be having a total of 5 subunits. They are referred by the traditional names like alpha, beta, then gamma, delta, epsilon. And it is the alpha subunit which is of concern because the moment this one is activated, the alpha subunit, that is when sodium influx would be occurring, and then subsequently it will be causing a depolarization, and they would be firing at the neuromuscular end plate and the muscle will be able to contract. In this condition, what happens is that we have antibodies which would be affecting this acetylcholine receptor. So the name would be called as anti-AChR, that is anti-acetylcholine receptor antibody. And what it will do, the function of this antibody is, first it will cause blockage or blockade of the receptor. And what I mean by blockade is that it will mainly affect the alpha subunit, and therefore the depolarization part will be affected, and therefore the contraction of muscles will also be significantly reduced, what we called as myasthenic fatigue. The second problem that occurs in these patients would be a increase in the turnover of the receptors as well. Therefore, the time for which the acetylcholine is able to activate the receptor will also be substantially reduced. The third thing that happens in this patient is damage to the, and that would sound very surprising if you're reading for first time, this causes a proper physical damage. The antibody causes the damage to the postsynaptic muscle membrane. This is a little surprising statement because I said the antibody is not only affecting the receptors but is actually causing physical damage to the muscle membrane as well. And I'll talk about these antibodies as we progress in the discussion. The fourth problem in this condition is called as presynaptic rundown. Now, to explain presynaptic rundown, I can say like this, that if you are trying something and you are not succeeding in that, like you have tried 2 times, you have tried 3 times, and you are not able to do a particular task, then your enthusiasm towards that activity tends to reduce. I mean, our normal psychology would be like this, no, like I have tried to do something 3 times, it's not working. I need to obviously motivate myself to do it the fourth time, but then our enthusiasm, when we are doing something for first time, the enthusiasm is like super high, and then obviously it becomes routine for us. Similarly, here I'm saying that the pre-junctional site is causing release of acetylcholine, but it is not being able to activate the receptors because of the reasons which are mentioned here. So ultimately, the presynaptic release of acetylcholine can also be affected in these patients, though marginally, not very significantly, but still that will contribute to the disease process because ultimately the firing of the neuromuscular end plate would be affected. So if you look at these four things, one of the common parameters or one of the common concepts that you can understand from this is that due to all of these effects, the efficiency of neuromuscular transmission is affected significantly big time, and therefore the ability of the muscle to perform will also be reduced. If you look at this report that I have shown on the left hand side, this is basically a repetitive nerve stimulation test, and it's a straightforward test. I mean, you would stimulate a nerve at a low frequency, then at a high frequency, and when you stimulate, obviously the muscles, as they keep on performing, their performance keeps on reducing, but usually the performance reduction is less than 10%. But here you can see a substantial reduction in the performance of the muscle as we are continuously stimulating the nerve. The reason for this is that the acetylcholine is not being able to activate its receptors properly due to the varied reasons that I have mentioned. Therefore, the technical term that is a very good pickup point in MCQs of myasthenia gravis is this terminology that I'm saying, decremental response. You know, you read a question of a young female having easy fatigability, she gets tired very soon, there's ptosis, there's diplopia, which I'll explain to you the clinical features. But the question then goes on to say this word decremental response, you know that you are right away making a diagnosis of myasthenia gravis. Why I'm saying that? Because you see, when I will describe Lambert-Eaton syndrome to you, there also I might talk about a female with manifestations of ptosis and maybe a diplopia and chewing muscle weakness, but I will there be saying the word incremental response, and here I'm using the word decremental response. So that's why the significance of it, because the symptoms of myasthenia gravis and Lambert-Eaton syndrome can overlap partially in that, though there are technical differences also which we will learn, but because of the overlapping of the symptoms, it is imperative that you try to understand the differences between the two. So the question that will arise here will be that why is this patient having these manifestations? In fact, clinical studies have shown that 75% patients of myasthenia gravis are having a thymus abnormality. In fact, 65% are having a thymic hyperplasia and 10% are having a thymoma, and they are the villains behind development of manifestations of this person. Thymoma, as you know, is a benign tumor. It can spread locally, it can press on the recurrent laryngeal nerve. But today, I am more concerned not about the mass effect of this tumor, but rather the antibodies that this chap is producing, which would ultimately be causing developmental damage. So they did a little bit of more research to find that what is present in the thymus, which is having an antigen against which the antibodies are found. They found that thymus will be having these cells that are called as myeloid cells. On the surface of these myeloid cells, there is a alloantigen, that is the antigen against which antibodies are formed, and the chemical structure of this antigen resembles the acetylcholine receptor. So the antibodies, they are actually designed against the myeloid cell surface receptor, which is gonna be having a structure similar to acetylcholine receptor. And once the acetylcholine receptors are affected, then the functioning of muscles would be affected. The antibodies which are found in this condition are all T cell dependent and are IgG class. The importance of studying that the antibodies are IgG class would be that they can cross the placenta. So if a mother, like a young lady, of a myasthenia gravis, autoimmune diseases are common in women. So when this autoimmune disease, when this lady will conceive, she can transfer this antibody to her baby, and congenital myasthenia gravis or neonatal myasthenia gravis could be a presentation in this case. We need to now know the names of the antibodies. We need to know the names of those villains which are responsible for this condition. And the first one on the agenda is a straightforward name that I've said right in the beginning: anti-acetylcholine receptor antibody. This will block the receptors of acetylcholine, will affect the alpha channel, and therefore acetylcholine won't be able to go in. About 85% patients will be harboring this anti-acetylcholine receptor blocking antibody, but then you will also read a second name, which is all the way important because we tend to give less importance to reading this usually, that is anti-MuSK antibody. The full form would be muscle specific kinase antibody. This antibody is found in total of 10% patients of myasthenia gravis. Mostly it is found in those patients who are acetylcholine receptor antibody negative. The prevalence of this antibody is total of 10% and is more common in those in whom the first antibody is negative. The second antibody, the special name that is to be remembered, second special name, otherwise it's third in the serial order, would be called as anti-LRP4 antibody, a very peculiar name. So let's have a look at the full form here. That is a low density lipoprotein. Now, traditionally we study about LDL, HDL, etc., but then a slightly overlapping name containing antibody that has to be remembered. It is called as LRP2, that is lipoprotein, low density lipoprotein related protein 4 antibody. Once you get the name right, the fourth one is even more surprising as a name. This would be called as anti-netrin 1 receptor antibody. So you would be wondering that how many names I'm gonna tell you. So I'm gonna tell you total of 6 antibodies which are found in this condition, and that's one of the main reasons why we have updated this lecture, because in the new edition of Harrison, these names are given which you should be aware of. Like the name is anti-netrin 1 receptor. Coming to the fifth one, that would look a little surprising again. Tongue twisting name, Caspar-2. The sixth one is which I said even in the starting, I said that the antibodies in this condition, they attack the muscles also. So agreed that this is a disease of neuromuscular junction, but the antibodies attack the muscle also. The antibodies in this condition have been demonstrated against the largest muscle protein, that is called as titin. Titin is also called as the muscle spring. It's the largest muscle protein. The molecular weight of that is fairly big. It's even molecular weight wise bigger as compared to dystrophin. So the antibody is called as antibody against titin, or is technically called as anti-striated muscle antibody. There are total 6 names. of the antibodies which are the villains which are responsible for this condition, out of which the most common one is this one. The prevalence of this antibody is about 85%, whereas anti-musk antibody prevalence is 10%, and the remaining antibodies are found rarely, but then because of these specific names like LRP4, Natrin1, Casper2, you just need to have a hang of these names present here. All of these are IgG class of antibodies, so the ability to cross the placenta is very much present. So let us now study regarding the problems that will be occurring in the patient because of this autoantibody. Prevalence of myasthenia gravis is substantially high, at least in Western populations. So Harrison has given the figure to be 200 cases for every 100,000 population, which is substantially high. The disease is more common in young age females or in men after 50 to 60 years of age. So don't be surprised if a myasthenia gravis question begins by saying a male, but his age would be on the higher side. The disease can obviously be showing a exacerbation. It will be having a waxing and a waning course. The exacerbations can be triggered by infection. The exacerbations can be triggered by pregnancy, and in fact in some of these patients the condition can become so bad that a young female might be fighting for her life at the time of pregnancy. When she goes into myasthenic crisis, there would be a diaphragmatic paralysis developing in a patient. However, the earliest manifestation that will develop in this patient would be that of ptosis. In the image that I've shown before you, however, I've deliberately not shown ptosis because you know about ptosis, drooping of the eyelid from ophthal. Rather, I've tried to show that in this young lady who's suffering from myasthenia gravis, you can notice that she has involuntarily, she's elevating her eyelid to keep her eyes open. When she was asked for medical photography, you can see that her eyelid is a little elevated, right, a little elevated. So most patients of myasthenia gravis initially do not realize that they're having a ptosis. They, because if you have ptosis, your vision will be impaired, so the person will subconsciously use these muscles of the forehead to elevate the upper eyelid so that the eyes can remain open. Just to explain this, I can say that I had a young student of mine who was suffering from myasthenia gravis, and her problem was that when she's sitting casually, not a problem, but when she's watching television, or if she's fiddling around with the smartphone, or when she was giving exam, when she has to focus on the screen in the computer, that is when the ptosis used to develop. So she realized that she has a problem after listening to one, what I was saying, and second, when she was sitting giving these or mock tests, etc., on her computer, laptop, or mobile phone. Every time she used to focus, she used to have this drooping of the eyelid, and then she used to have difficulty in seeing the screen, and then she realized she had a medical problem. So, I mean, a doctor having a problem, you can understand, and not realizing that there's something wrong, because most of the time the disease is found in young females, and due to lack of awareness, I would say, and mild manifestations initially, a person may not realize what is going on. The earliest manifestation in these patients is development of ptosis and involvement of the extraocular muscles. Do appreciate the fact that myasthenic weakness is more in the evening hours as compared to morning hours. There will always be a diurnal variation of history given in this question. Weakness and fatigability are two very non-specific terms. If you're lazy, you might say, I am weak, I am fatigued. But if you read a question that describes the words that I said, that patient is okay in the morning, but by evening hours there is development of symptoms. If diurnal variation is described in a question, that definitely tells you that you bang on track for diagnosis of myasthenia gravis in a patient. Let me explain this a little further. Let us assume this to be representation of the cornea, and the upper 2 millimeters of the cornea is always covered by the upper eyelid. Like in this diagram, I am trying to draw before you the fact that upper eyelid 2 millimeters is always covered by the cornea. In patients of myasthenia gravis, when she wakes up in the morning, she will not have any ptosis. But suppose she is watching television news, or she is fiddling around with a smartphone, then there will definitely be stress on the eye muscles, and that will trigger a ptosis in the patient. And when you examine the patient, you will notice that this ptosis will never be symmetrical. It will always be a asymmetrical ptosis developing in a patient. If this patient has not watched television, then you may not get these manifestations immediately. Then the patient will say that in the morning I'm okay, but by evening I'm not sleepy, but my colleagues are asking me, why do you look so sleepy head? Your eyes are literally shutting down. And if this person is working on a computer in the office, she will have to involuntarily use her forehead muscles to elevate her eyelid to type on the computer, because obviously if you have ptosis, you can't see the screen properly. So you raise your neck initially and start typing like this. Then you raise your use the muscles of occipitofrontalis, try to elevate upper eyelid, and thereby try to type. So most of the time, these patients will relies on working that they are having symptoms. And because I have said that in this condition there is a asymmetrical ptosis, that explains why there would be a double vision developing in the patient also. Because if it was symmetrical ptosis, then images of both eye would be, equally developing, equally obliterated in the brain. So there would be no diplopia. But because it is asymmetrical, there would be a double vision occurring in the patient. So highlight of myasthenia gravis would be either a young female 30s, for example, or a man 50-60 years of age with asymmetrical ptosis and double vision. In fact, in these patients, you don't need to even wait till evening and let them suffer from a symptom and then tell them, okay, you have myasthenia gravis. Like patient came in the morning, there's no ptosis, but she's telling you I have weakness of my eye muscles. I feel my office colleagues, they tell me that you look sleepy all the time. My office colleagues, they make fun of me that I am a sleepy head. Though she does not feel sleepy, but she says I it looks as if I'm sleepy because eyes are half shut. So what you will request this person to do is simply a upward gaze. Like you and me can look up, down, sideways as long as we want. But in myasthenia gravis, when you will request a upward gaze in the patient for as little as 30 seconds, like you ask the person, look up to the roof of the clinic. Like I'm looking up, so I'll ask the patient, look up to the roof of the clinic for as little as 30 seconds, and there will be a development of symptoms of ptosis and diplopia in the patient. At this junction, I want to tell you that some patients might be having only the extraocular muscle weakness as a presentation for whole of their life. If the symptoms of extraocular muscle weakness exclusively only persist for duration more than 3 years, then the term that is used to describe the features is called as ocular myasthenia gravis. I repeat once again, a lot of patients of MG may not be having generalized myasthenia gravis. They have ocular myasthenia gravis, and that would be when the symptoms persist for a duration at least for 3 years. In this case, you should obviously do a CT or a MRI head to rule out any CNS cause. Like there could be a berry aneurysm that can also contribute to ptosis. Like I have explained that unruptured berry can press on the oculomotor nerve, especially if the berry is present in the posterior communicating artery, and it can cause a development of ptosis in the patient. So you have to do at least a baseline CT or MRI head to rule out any CNS lesions which could be contributing to extraocular muscle involvement in a patient. And in this condition, obviously the problem is not any mass effect of any tumor or aneurysm going in the brain, but it is a neuromuscular function at the junction which is not occurring properly. Now I have asked this lady to smile. Now when you and me would smile, there would be a big smile, but in this case you can notice that that snarling appearance coming up. So patients of myasthenia gravis are said to be having what is referred in the book as snarling facies. That's again a good pickup point for MCQ. Snarling faces are a feature of myasthenia gravis. They may not be visible initially. I said when you ask them to smile, instead of smiling from corner of the mouth, you can see that the mouth is partially open, and there's like the person is having the slight elevation of the nose. So that's like when you're angry, right, or snarling. So snarling faces, like I put a snarling face right now, right? Snarling faces is a feature that is found in patients with myasthenia gravis. Moving ahead, because this is not a very important diagnostic feature. I mean, if I am like sitting like this, that does not mean I have myasthenia gravis. So I have just mentioned that learning faces is a feature that you will notice over a period of time in the same patient. But the third feature that I say will be very characteristic for this patient, and that would be based on the fact that when this person is eating non-veg food, like this person is eating chicken or meat, because you have to chew, non-veg you have to chew as compared to vegetarian food, which is softer. So every time this person is chewing food, it is taking longer time for the patient to finish the meal. The patient says that I am the first one to sit on the dining table in my family and last one to get off it. People think I eat a lot. Person says, look, I'm so skinny, I hardly eat anything, but because it takes long time to finish the meal. Or I can give another example, like if you and me are late for college or hospital, we can just quickly gulp down a glass of milk and rush to work. If you ask a myasthenia gravis patient, okay, try to drink a glass of water fast, lots of time they might literally choke on it, or water might come out of the nose of the person. So pharyngeal muscles, tongue muscles, they cannot function like normally. So ability to eat fast, ability to swallow food fast will not be present in these patients. Therefore, the third point of our discussion would be chewing muscle weakness in a patient. This chewing muscle is more prominent. Muscle weakness is exaggerated on eating non-vegetarian food, especially like meat or mutton, etc. When the person is consuming, that's when the manifestations become a little more exaggerated. You will also notice that if the person will speak continuously, like we people are, talking with our friends all the time, so our voice pitch remains the same, but in these patients, because of the weakness of the pharynx, the weakness of the muscles of the throat, there can be development of nasal twang in the patient, especially the weakness of the soft palate is I'm talking about, because soft palate also plays a role in phonation. So the soft palate weakness will contribute to nasal twang of voice. The family member might initially say that you were trying to prank me, like if somebody is talking to you with a nasal twang, you might think the person is trying to put a prank on you. But then the family member will realize that there's something wrong, because when the person starts speaking initially, the speech is clear, but then gradually the nasal twang of voice would start coming in the patient. Similarly, there can be nasal regurgitation of fluids. When the person will drink water, coke, whatever, it might come out of the nose. Like this person had to rush to college because the patient was late for college, and then person tried to drink milk and start coming out of the nose of the patient, and risk of aspiration is very much there. Especially in myasthenic crisis, aspiration risk will be so high that you will have to admit the patient in intensive care unit and manage the patient conservatively. When I say the word dysphagia for these patients, the impression is that esophagus is involved, but please appreciate that esophagus is smooth muscle, and this is not a disease of the smooth muscle, this is a disease of the skeletal muscle. So therefore, because the tongue cannot perform like a normal person, I'm writing the word oropharyngeal dysphagia can also be described for these patients. To summarize these points, I can say the voluntary muscles related to the pharynx, the tongue, and the soft palate are not going to be able to function properly. Therefore, these manifestations will occur in the patient. In fact, in some of these patients, even muscles related to vocal cords will be affected. So even dysarthria can be written in the patient. Meaning of the word dysarthria is unclear speech. So there are two reasons why the person is not able to speak properly. One is the nasal twang to the voice. Second is dysarthria related to muscles of the vocal cord. Because when this person will speak continuously, like you and me can go on speaking for half an hour, 1 hour without any change in the pitch and quality of the voice. But in this person, the unclear speech will start developing after continuous speaking for 2 to 3 minutes. The highlight of this disease is that in spite of all this motor weakness that you're getting in the patient, the deep tendon reflexes in these patients are preserved. I highlight this fact once again. The muscle weakness is prominent in these patients. It increases with activity of the same muscle. There's a diurnal variation of features in these patients, but in spite of all this motor weakness that I'm talking about, the reflexes in these patients are preserved, unlike Lambert-Eaton syndrome, which we will discuss subsequently, where reflexes are definitely affected. DTRs, that is knee jerk, ankle jerk, would be normal in these patients. Sensory function is not affected in these patients. So sensation in the throat is preserved. There's no problem with the gag reflex per se. Gag reflex, if you try to elicit, it will definitely be there in the patient. But the deep tendon reflexes are also preserved in the patient, but the motor weakness is still very much there. So that's how clinically you get an idea regarding that this could be myasthenia gravis occurring in a patient. Now, do you have arm weakness in myasthenia gravis or leg weakness in myasthenia gravis? The answer is yes. Like if you ask this person to, spread out arms like this and keep your arms abducted, like if I'm keeping my arms abducted like this, then you will notice that even shoulder muscle fatigue will start developing and they would be drooping in the arms of the patient. So muscles of the hip joint, muscles of the shoulder joint can also be involved in the patient, but this is rather a late manifestation in the disease, that is proximal muscle weakness. Whereas when I will describe Lambert-Eaton syndrome to you, there the primary complaint will be proximal muscle weakness, whereas in myasthenia gravis it is mainly related to the eyes, it is related to chewing, it is related to swallowing. So the routine things that we don't even realize, no, like you are listening to me, you are blinking, you might be drinking water in between you might be attending a phone call. So all those things that we don't even think about, like blinking, talking, or drinking water, etc., those are the things which are affected in this patient, and it is only later that shoulder girdle weakness. And how would the patient tell you, I'm having shoulder girdle weakness, I'm having this deltoid weakness? A patient doesn't know deltoid, what is shoulder girdle. So suppose it's a female, she has long hair, so she says, when I comb my hair, I feel as if the comb has become heavy. The first time when I listened to this, I was literally laughing on the patient. I said, "Are you crazy? I mean, you telling me comb is becoming heavy, plastic comb is becoming heavy." What this lady was indirectly trying, I mean, she can't understand this. She was basically telling me that a deltoid, when you comb your hair, right, you have to raise your arm above the level of the head. Like you have to brush your hair, you have to raise your arm above the level of the head. So when she used to do this brushing activity or combing of the hair activity, the deltoid weakness used to manifest in the person in the sense that that comb used to be perceived as becoming heavier in the patient. So earlier I was not a wise person, I will say. Knowledge is, I've been saying this every time when I teach, that knowledge is power. So well, I did not realize, I was smiling at the patient when I thought I'll refer her to psychiatrist for it. Then I realized it's my lacuna, it is lack of knowledge on my part, that I was not being able to identify the disease and what the patient was saying. So spend more time with patients. That's the learning here, and these are the manifestations that would be encountered in these patients. Coming to the workup that I'll be doing for this suspected case of myasthenia gravis, the screening test would be answered by you as the antibody, which has come up in our discussion multiple times, anti-acetylcholine receptor blocking antibody. This is positive in 85% of the cases, so you know that you have reached your diagnosis. If this is positive, I mean the probability of diagnosis has increased manifold. But this antibody can be negative as well. So let us understand the limitation part, which would widen our understanding of the disease. The first limitation is that if the report is negative, the negative antibody test in this case does not rule out the possibility of myasthenia gravis. That is one. I mean, positive is myasthenia gravis, negativity is not ruling out myasthenia gravis. Second, this does not correlate with the severity of the disease. Now we have to study what antibody would be found in those patients in whom this antibody is negative. This would be called as anti-MuSK, that is muscle specific kinase antibody. The third antibody which is found in this condition is anti-LRP4. I have taught you other antibodies beyond these also. I'm not mentioning the names because in the diagnostic protocol, those names are not given because they are not found routinely, or those tests would be offered only by research laboratories. Routine commercial laboratories would be able to offer you testing for mainly three: acetylcholine receptor antibody, then anti-MuSK antibody, and anti-LRP4, that is lipoprotein or low density lipoprotein receptor protein 4 antibody. So once we have done these tests, we are sure about our diagnosis, but we need to be more sure. So he says for confirmation, what will we do? That would be called as SFEMG, that is single fiber electromyography. The findings in this case would be referred to as a jitter and blocking, which simply means the fact that the amplitude of contraction will not be substantial as it should be as a normal muscles performance. Single fiber electromyography kit is a little expensive and may not be available in most government hospitals. So if you visit neurology department of yours, they might tell you that we are doing a test by the name of repetitive nerve stimulation test. That's relatively straightforward. No, I mean, just need to purchase some electrodes, and you should obviously have a setup where you can record the discharges of stimulation of the muscles when you stimulate a particular nerve. So the setup is relatively cheaper for repetitive nerve stimulation test, and it will be showing a classical decremental response. But abroad, where facilities are relatively more, I would say that they are first answering single fiber electromyography. In fact, Harrison has used this word confirmatory test. I mean, if it is negative, then you cannot rule out myasthenia gravis. But if this is positive along with antibody, then you know that your diagnosis is spot on in the patient. So if he says in the question, what is the screening test to be done? The answer should be given as antibody titer, that is anti-ACH receptor antibody, confirmatory single fiber electromyography. Electrodiagnostic tests are always to be given preference over anticholinesterase test or tensilon test. So I would put it like this. When I used to teach 5 years ago, I used to teach your senior batches that the first test to be done for evaluation of myasthenia gravis is tensilon test or anticholinesterase test. But now you can see that I have not even mentioned regarding the tensilon test slash anticholinesterase test. Why? Because that's now a backup. They say that with tensilon test, there's a possibility that patient can land up in cholinergic crisis, and in diagnosis, if a person goes into cholinergic crisis and dies due to aspiration of saliva, etc., it's a big medical legal problem for the patient. So that test has now been relegated, I would say, rather to the back seat. The test which was first or primarily called as a first test to be done or the screening test for myasthenia gravis. Tensilon test is now on the back seat and it is done only for difficult to diagnose cases. For point number 6 of our discussion, that is the workup of this patient, I would like to highlight this fact. I have a suspected myasthenia gravis patient in my clinic, and I have told her that, ma'am, you need to look upwards to the roof of the clinic. Uh, and when she is doing this activity, I will be securing a cannula in the dorsum of her hand. So the first step in Tensilon test is ask the patient for a sustained upward gaze that will trigger ptosis in the patient. It would be asymmetrical bilateral ptosis. Now, since I've secured a IV line already, by the time the ptosis will start occurring in the patient, the IV line is in place. I have used leucoplast, etc., to secure the IV line. My nurse will hand me over a syringe that is containing 10 milligram of hydrophonium. This molecule is a short-acting anticholinesterase agent. If you will give this injection intravenously, the onset of action will be after 30 seconds, and the maximum action of this drug or the duration is about 5 minutes. So I would put it like this: like if you give this injection, it starts working of 30 seconds, and the peak effect of the drug will start coming, and beyond 5 minutes, the effect of the drug will start waning off. Out of 10 milligram, we straight away do not push 10 milligram right away because it can trigger cholinergic crisis. So first we will give 2 milligram to the patient, and what this molecule will do, hydrophonium will do, is that it will inhibit the degradation of acetylcholine. You see, in myasthenia gravis, the problem is acetylcholine comes, it is not able to activate the receptor. Now, what I am doing is I am inhibiting the degradation of acetylcholine. So, acetylcholine will be able to act on the receptor for longer duration. I am not increasing the amplitude of contraction here. I am increasing the duration of contraction. I repeat once again, if I inhibit the degradation of acetylcholine, it will be able to cause a muscle twitch for longer duration. So amplitude may not be significantly increased, but the duration of the twitch will increase. That will still increase the power for me. Most of the time, when you give 2 milligram of hydrophonium, if this is a genuine case of myasthenia gravis, there will be a marked improvement in the patient. If there is no improvement, then you can push the remaining 8 milligram of the hydrophonium in the patient and wait for a clinical response. And what response will you check? You will look at the ptosis component, or you can ask the patient to separate the arms before the performance of the test like this and see how long person can hold the arms in abduction position. And after giving injection, you can compare. It's easy to identify the ptosis component because the ptosis component will significantly reduce. The moment you give a shot here, the nurse will switch on the timer. When 30 seconds will pass by, you will notice that her ptosis has become lesser and will then totally disappear, and after 5 minutes will reappear. So I have said three things. I said first ptosis will become lesser, then will become absent, and then will reappear because the effect of the injection will go away. So this test that I mentioned before you is called as anticholinesterase test. This inhibits the breakdown of acetylcholine. It is also referred to as Tensilon test. During the performance of the test, the patient can land up in cholinergic crisis. How do I know it is cholinergic crisis? The patient will develop sludge symptoms. That would be hypersalivation because there's excess acetylcholine. No? So there would be hypersalivation, and this hypersalivation can be troublesome because patient might aspirate saliva and die. There have been instances when patients have become really very sick, like during the performance of the test, the patient literally aspirated saliva, had to be admitted into ICU. So relatives will obviously say, we came for diagnosis and you landed us in intensive care unit. So now this test has been put on a backseat mainly because of the practical issues with it, as I've explained to you, though it looks very simple to perform. I mean, this looks like a very easy test to perform. Still, I am saying that it is on the back seat or it is not given in the front primarily because of hypersalivation, hyperlacrimation, then frequent urination. So person will ask for washroom breaks. Then D would be diarrhea and GI complaints. E would be meiosis in a patient. So I'll repeat the features once again. And I'm not written them because they're very straightforward. Hypersalivation, lacrimation, frequent urination, diarrhea due to increase of GI motility, and eye manifestations, meiosis in a patient. So during the performance of this test, if you are having a cholinergic crisis, atropine has to be given to the patient. And because of the medical legal issues, the practical issues which I mentioned here, now instead of using a Tensilon test, we have another alternative available at our disposal, and that would be to go in for a ice pack test. Ice pack test would simply mean that you would be asking this patient, I'll just show you an image that will make it easier for you. Like this person, you can see this is a male patient. I told you that myasthenia gravis is seen in young female and in men between 50 to 60 years of age. So you can see here that this man is having a ptosis. It's a asymmetrical ptosis that is present. Now I have taken some ice, rolled it in a glove or maybe a commercial ice pack which comes with vaccines, etc. And I have just put it on the eye of the patient, and you are noticing that post application of a ice pack for few minutes, which could be about 3 to 5 minutes, the ptosis of the patient has substantially reduced. So what really happened? I mean, why is it that something as simple as application of ice is contributing to reduction in the symptoms of the patient? So one, the enzyme responsible for degradation of acetylcholine, you all know acetylcholinesterase, that is very sensitive to temperature. If you decrease the temperature, then the activity of acetylcholinesterase enzyme tends to reduce. So if acetylcholinesterase is lesser, acetylcholine won't be broken down, and therefore there would be a better action available. The test that I mentioned before you, ice pack test, has a sensitivity equivalent to that of tensilon test. This was actually observed by a patient itself, and this patient was actually a male nurse, and he realized the fact that every time he used to splash cold water on his face, his symptoms used to reduce. So from there, it just picked on that, using ice pack test, we can identify or suspect myasthenia gravis in a patient, and they found surprisingly that the sensitivity of this test is equivalent to that of tensilon test. So nobody wants to take a chance nowadays and do a tensilon test at least on OPD basis when you have something so simple available. Even in this condition, you will be asking the patient for sustained upward gaze, and there will be induction of ptosis in the patient. It would be asymmetrical ptosis. When you apply the ice pack, what it will do is it will do two things. First, it will inhibit or it will decrease the activity of acetylcholinesterase enzyme. ACHE basically means acetylcholinesterase enzyme at the neuromuscular junction. So the degradation part has been reduced. Second, it will also contribute to a decrease in the turnover of the receptors. You see, the acetylcholine receptors are formed, then they're degraded. So this degrades the turnover of the receptors as well. In myasthenia gravis, the turnover of the receptors is increased. Here we are having a downgrade of turnover of the receptors. So ultimately, acetylcholine values are increasing, and they are able to act on more number of receptors. Both is for benefit for us. I repeat again, I said more acetylcholine is coming. Why? Because the degradation part is not happening, and there is also a more receptors available. So the performance of the muscle will increase as compared to previously. So we do a ice pack test for these patients. The next point that I say to you is very important from MCQ perspective, that I will be doing a CT head or MRI head in these patients. Why? Because I want to rule out causes like arteriovenous malformation or any space occupying lesion contributing to third nerve palsy or ptosis occurring in a patient. So that's one baseline test that is always to be done, and it is mandatory to anyway do this test in all cases of ocular myasthenia gravis. I have explained that extraocular muscle weakness for more than 3 years consecutively is called as ocular myasthenia gravis. The next test will be a CT test for these patients. Now that again looks very surprising if you're casual. Why do you want to do a CT test in the patient? One, because I want to pick up any mass effects of thymoma. I also want to demonstrate whether there is a thymic hyperplasia in a patient, because after all, the treatment of choice for myasthenia gravis or the generalized variety is thymectomy. So thymus is the villain. Get it out. Studies have shown that thymectomy should be done in all cases of myasthenia gravis. Why? Because even if it is a patient who will require steroids, after all, because it's an autoimmune disorder, the dosage of steroids is reduced. That's a big boon to you. Quality of life is improved, because if you are having lesser requirement of steroids, then the side effects of steroid toxicity are substantially reduced in the patient. So CT chest is done to rule out the thymus abnormalities in the patient. Then these patients can be having coexistent autoimmune diseases. Those could range from Hashimoto's to Graves' disease, SLE, rheumatoid arthritis, and therefore in the workup of these patients, I need to do an anti-nuclear antibody. I'll be doing a RA factor in the patient, and at least a baseline TSH can be done in the patient, because in Hashimoto, if the person has reached a hypothyroid state, then the values of TSH would be high, and in Graves' disease, the TSH values would be literally undetectable. So TSH, anti-nuclear antibody, and RA factor is done to check for coexistent autoimmune diseases which could be present in this particular condition. The last two tests that I mentioned for this condition have to be listened with utmost care, because they are in the end, so we tend to get fatigued and we tend to miss them out. One, pulmonary function testing should be done in all of these patients. Why? Because we need to plan thymectomy for these patients. So I want to look at the lung reserve of the patient, like if he's a obese person, and because possibly the person of myasthenia gravis might have been on steroids for long duration, so the obesity component might have developed in a patient. So I want to have a look at the lung function of the patient before we plan a surgery for a patient, because if you do a chest surgery, lung functions have to be evaluated. Then, because you give steroids for immunosuppression in all patients of myasthenia gravis, or in most patients of myasthenia gravis, immunosuppressive drugs like prednisolone, azathioprine have to be given. If tuberculosis is present in a patient or diabetes is present in this patient coexistently, then they will worsen. Steroids will worsen tuberculosis, steroids will worsen diabetes mellitus by increasing the blood sugar values. So the textbook says that glycosylated hemoglobin values and baseline test for TB, like at least a tuberculin skin test, should be done. And these are two statements important MCQ wise, because immunosuppressive treatment, whenever it is planned to be start in any patient, like even in pediatric cases of minimal chain disease, before we start prednisolone, we have to be careful that the child is not having tuberculosis, because you give steroids for minimal chain disease, the tuberculosis part will flare up just like anything, and there could be dissemination of the disease also. So diabetes mellitus and tuberculosis should be ruled out by investigation part before initiation of immunosuppressive therapy is done for these patients. Once we get the tests for this condition right, we will now look at what is the therapeutic options that we have at our disposal for management of these patients. Coming to the treatment part for patients of myasthenia gravis, the first thing that I would like to mention is usage of pyridostigmine. In pediatric cases, we are more comfortable giving neostigmine to the patient, but in adult cases, it is pyridostigmine which would be answered as the best drug to limit the symptoms of the patient. The onset of action of this medicine is after 15 minutes, and the total duration of action is approximately 4 hours. So, repeated dosages of pyridostigmine have to be given to these patients for causing symptomatic relief. Do remember the fact that patients who are having these anti-MuSK antibodies present, they may not show a good response to this drug. Generalized myasthenia gravis, the response is going to be much better. In fact, surprisingly, in some cases, when you give this medication, there might even be worsening of patients' symptoms. So do keep a watch for persons who are anti-MuSK antibody positive. They should follow up with you regularly, because worsening has been documented with pyridostigmine, but it is a preferred drug to be used, or DOC from pharmacological perspective is obviously pyridostigmine and not neostigmine. Now, what is the role of thymectomy for the patient? So thymectomy will be answered as the treatment of choice for this condition. I repeat my statement, the drug of choice would be answered as pyridostigmine for symptomatic relief in the patient. If the question uses the word what is the treatment of choice for patients of generalized myasthenia gravis, then answer should be given as thymectomy. Now, why do we do thymectomy? There are two aspects that I would like to say here. One, it is always to be done for thymoma because it can expand locally. It's a benign tumor, but it can expand locally and cause a mass effect. So I want to handle that. And second, they have documented the fact that even if person is not having a thymoma, suppose he's having a thymic hyperplasia, it is advantageous to remove the thymic hyperplasia, because the subsequent requirement of steroids that you prescribe for these patients in the long run significantly reduces. I repeat my statement. Why do you give thymectomy in the patient? One is obviously resection of a thymoma. Before doing a thymectomy, a pulmonary function testing must be done thoroughly. I mean, the anesthesiologist should be clear with respect to the lung function of the patient, because we don't want any post-operative complications, because anyway, surgery can also trigger a myasthenic crisis in the patient. So the anesthesiologist has to be good in ventilation, both intra and post-operatively for these patients. I mean, it might take a while for these patients to come out of anesthesia also. So therefore, the anesthesiologist has to be the one who has previously handled cases of myasthenia gravis, because intra-op complications and post-op complications in these patients will be more, especially with ventilatory drive being limited in these patients secondary to diaphragmatic involvement. Now, once we do a thymectomy, after we are satisfied, it is one for resection of thymoma, and second is the decrease in the requirement of immunosuppressive drugs, because long-term intake of steroids can cause Cushing syndrome, visual defects, cataract in a patient, myopathy in a patient. So sometimes if we do not offer thymectomy, patient will obviously tell you, oh, I don't want surgery, I want medication. But the same patient will say, doctor, had you told me earlier, I would have decided, because steroids after 5 years, when they start causing Cushing, where it faces, or in a female there's hirsutism, that is when they start blaming you. So Indian patients will obviously be, in a blame game one, and usually they refuse surgery initially. But our objective in generalized myasthenia gravis is mainly to convince the patient to sign up for thymectomy as early as possible. In ocular myasthenia gravis, however, the protocol says that first give pyridostigmine, and if it's a poor response, then straight away go for immunosuppression. Do remember my words very carefully. We do not recommend thymectomy in ocular myasthenia gravis. Studies have shown that for ocular myasthenia gravis, first line drug is pyridostigmine, obviously, for symptomatic relief. Though if a person is anti-musk antibody positive, there might even be worsening, so watch out for the same has to be kept. If a person is having a poor response to administration and the symptoms are still persistent, working on a laptop is not possible, fiddling with the phone is not possible, typing in computer because the ptosis component is developing, then we have to start these patients on immunosuppressive molecules like steroids and azathioprine. Mycophenolate, obviously each one of them will have their relative side effects, and we need to weigh in the pros and the cons before we finalize a immunosuppressive treatment for the patient. MCQ wise, remember, ocular myasthenia gravis, we do not perform a thymectomy. It is in generalized myasthenia gravis where we perform a thymectomy in the patient. The protocol is like this. When you see the flowchart in Harrison, he says first give pyridostigmine and you will get a substantially good response in the patient. Now educate the patient regarding the benefits of thymectomy, because you anyway have to start the person on immunosuppressive medication. It's an autoimmune disorder. If the FVC of the patient is good and the consent of the patient is very much there, then a thymectomy can be performed in the patient. Post thymectomy, in these patients, we will still be giving steroids, but the dosage of steroids that would be required in this particular case will be very minimalistic. So I'm just putting one small plus and a couple of big pluses to highlight that the requirement of immunosuppressive therapy after thymectomy is substantially reduced. That is why he's saying in the MCQ or in the the questions that thymectomy is the best treatment for generalized myasthenia gravis and not recommended for patients of ocular myasthenia gravis. Do remember the fact that if he mentions regarding myasthenic crisis and what is to be done in the patient, then we will use plasmapheresis for these patients to get rid of the dangerous antibodies. Myasthenic crisis can be triggered by, there are two triggers for it. One is infection and second can be pregnancy. Any kind of stress can trigger this kind of a crisis in the patient. So infection and pregnancy are the triggers in this particular case, and plasmapheresis would be done. If facilities for plasmapheresis are not available, it is intravenous immunoglobulin. If he says what is first to be done in myasthenic crisis, it is obviously elective intubation and ventilation of the patient. We will have to maybe put the patient on assisted controlled mechanical ventilation because the PCO2 of the patient is beginning to rise and PO2 in the patient is significantly low. So crisis has to be managed on war footing. First line management is obviously get the airway access, and then the treatment of choice for crisis is plasmapheresis and intravenous immunoglobulins in the patient. At this junction, I would also like to mention regarding treatment for neonatal myasthenia gravis. Now, what I mean by word neonatal myasthenia gravis is that the mother of this child was having myasthenia gravis, and at the time of delivery and before delivery, she has transferred the antibodies to her child. Remember, the antibodies that are found in this condition are immunoglobulin G class, and all immunoglobulin G class of antibodies can very easily cross the placenta. Because of the transplacental spread of this antibody, the neonate will also suffer from a possible difficulty in establishing respiration. Therefore, a trained neonatologist or a pediatrician should be available to take care of the airway of the child. Assuming the fact that the delivery occurred in a good quality hospital and the resuscitation of the child was done, there have been absolutely no issues. Breastfeeding will still be a challenge because every time she will breastfeed this baby, there might be regurgitation of milk, there might be choking episodes, and the mother will obviously be very worried about the health of her child. So she's asking you, doctor, what is to be done, and you have told her that I'm prescribing some drops for your child which have to be given regularly to your child every 3 to 4 hours. She says, okay, doctor, no problems. But for how long? She says, I mean, doctor, are you serious? You telling me that every 4 hours, like 6 times in a day, I need to, even if I'm sleeping in the middle of the night, I have to wake up and give these drops to my child and not give a feed, because suppose the baby is crying at night, what a mother will do? Breastfeed the child. If she breastfeed the child without these drops, the child can aspirate and die. So she's asking you, doctor, I mean, are you telling me that I have to do this activity for whole life of the child? So I'll tell her no. That's not the case. Why? Because every antibody has a half-life. Antibody has not been produced by the immune system of the baby. The antibody has been produced, has been transmitted from body of the mother to the baby. The baby has acquired this antibody from the mother. She is the villain who was transmitted to the baby, and every antibody has a half-life. IgG usually gets destroyed by 21 23 days. So I would like to tell her that after 4 weeks of life, because this antibody will be destroyed by the immune system of your baby, he will not require any medication. That gets the confidence on the mother bag, and that explains to you why is it written in textbook and in MCQs neonatal transient myasthenia gravis, which means that after 4 weeks this child will not suffer from any problems because the antibodies will be cleared by the immune system of the child. This explains the fact that why it is written neonatal transient myasthenia gravis has a good prognosis. If you read it without this explanation, you would be wondering, no, on one hand I'm telling you diaphragmatic paralysis, and second hand I'm saying that child is not breathing, and second hand I'm saying that it is having a good prognosis. So the two don't gel together. But the missing link is that because the antibodies will be destroyed by the immune system of the baby, therefore the disease is self-limiting, and after 4 weeks of life no medicines are being required for this child. So drug of choice for neonatal transient myasthenia gravis is neostigmine for hourly for the first 1 month of life, and then it is goodbye to the disease forever. Once you understood this disease of the NMJ, we will now compare these manifestations with that of Lambert-Eaton syndrome. This would be called as LEMS in most of the MCQs. In Lambert-Eaton syndrome, when it comes to a male patient, most of the time the association is with aggressive lung cancer, that is small cell cancer of the lung. So this can be a paraneoplastic manifestation related to lung cancer. In Lambert-Eaton syndrome, the problem is that the production of acetylcholine is lesser. This is a presynaptic disease, whereas myasthenia gravis is a post-synaptic, post-junctional disease where the receptors of acetylcholine are defective. This is a presynaptic disease in which the release of acetylcholine is compromised. So let us see what's happening here. Let us assume that this is where the acetylcholine will be released, and you have these receptors available here. And when the muscle is stimulated and the muscle is able to act, in these patients we will be having production of antibodies. The antibodies which are present here, they go and they attack the neuromuscular junction, but they do not attack the receptors. They attack the area from where the acetylcholine release should occur. So here I've shown quanta of acetylcholine. They are the ones which should be released in this area. Now the antibodies will act on the prejunctional site and reduce the acetylcholine release, because of which I'm calling it a prejunctional defect. Therefore, due to less stimulation, the contraction of muscles in this condition will also be relatively less. The clinical features that will be noticed in the patients of Lambert-Eaton syndrome, however, will begin by first describing not eye or ocular muscle involvement and chewing muscle involvement, but the question will begin by describing mainly proximal muscle weakness. How will the proximal muscle weakness be described for this patient? The question might say difficulty in climbing stairs because the muscles of the hip joint are involved, or might say muscles of the shoulder joint are getting involved in the patient. So the word is proximal muscle weakness is the initial presentation of these patients. Subsequently, obviously, the feature will be ptosis, diplopia, chewing muscle weakness that would be written. So he might begin by saying a female. Remember, the incidence of lung cancer is mainly seen with male patients of Lambert-Eaton syndrome. In females, they may not be associated lung cancer, so that way the prognosis will be better in females. But question might begin by saying female, ptosis, diplopia, proximal muscle weakness. So it will sound like a question of myasthenia gravis only. So how would you know that this question is of myasthenia gravis or is of Lambert-Eaton syndrome? Are the following points that I say. Deep tendon reflexes in these patients will be substantially reduced. If you're listening to me carefully, you would have noticed that when I was teaching you myasthenia gravis, I had remarked this in the clinical features that deep tendon reflexes are preserved in patients of myasthenia gravis, but now I have told you that deep tendon reflexes in these patients will be substantially reduced. So reflexes can be one point of differentiation. Second can be autonomic associations in these patients. The autonomic features that can be written could be very innocuous sounding ones, like dry mouth being complained by the patient, or male patient having erectile dysfunction, so that is impotence. So when you read the question, these words might actually sound very harmless kind of symptoms or manifestations in a patient, but they have to be given their due importance. So if you get a question that looks like myasthenia gravis but then mentions these two highlights, you have to be a little cautious in answering these questions, as not straight away a diagnosis of myasthenia gravis. And well, what will be written in the question that would tell you with confidence that okay man, this is not myasthenia gravis, is what I tell you next. So listen to the next part with lot of care, which is repetitive nerve stimulation test. So the main point that will differentiate Lambert-Eaton syndrome from myasthenia gravis will be repetitive nerve stimulation response. If you will look at the amplitude of contraction of a normal person versus Lambert-Eaton syndrome, you will always be having very poor contractions or weak contractions occurring in the patient. You can imagine this to be normal amplitude of contraction for any one of us on nerve stimulation versus Lambert-Eaton, where the contraction is really, really poor. Because this contraction is poor, I will stop the test and I will ask the patient to do some exercise. I will say, okay, do some stretching exercises, raise your arm, move your arms a bit, do some possible squats if you can. So I will motivate the person to do exercise. When the person exercises, what happens is that the central drive in the body will increase. This will increase acetylcholine release at the neuromuscular junction. Remember, in this condition, due to autoantibodies, the release of acetylcholine at the junction is transiently reduced. But when you make the person exercise, the acetylcholine release at the neuromuscular junction tends to rise. So therefore, if I will resume the testing of this person post-exercise, I will notice that the amplitude of contraction will be relatively better. I'm not saying that the contraction will ever be able to reach normal, but you can notice there's a substantial increase in the amplitude of contraction. This is what is called as incremental response. And if you read a MCQ which mentions this word, that repetitive nerve stimulation test of a person shows an incremental response, then you have to answer in favor of Lambert-Eaton syndrome in a patient. Here, the query that I get from a lot of doctors is that if you are getting incremental response like this, why did you not make a myasthenia gravis person exercise? Well, I think you can all understand in myasthenia gravis patient also, if I ask her to exercise, if I pump her up, I say, okay, yes, you can do it. Imagine that you're running a race, you have to run fast, you have to ensure that your performance is good. Acetylcholine release will occur because I have motivated the person is trying to exercise, but at the same time, the acetylcholine that is being released will not be able to stimulate the receptors. Why? Because the receptors are blocked, the receptor sites are not working, it's a post-junctional defect. So any kind of pep talk and exercise on the part of the patient is not going to improve the symptoms. Well, for you guys, what is the message here is that patients of myasthenia gravis, when they wake up in the morning, they're okay, but by evening, the performance goes down. In Lambert-Eaton syndrome, it is opposite. When they wake up in the morning, they are weak, and when they start doing activity, the performance starts increasing. I repeat the statement once again. I have today taught you two diseases of the neuromuscular junction which have a diurnal variation of symptoms. What I mean by diurnal variation is, in myasthenia gravis, patient in the morning is just like you and me. By evening, it's like eyes are closed. In Lambert-Eaton syndrome, it is opposite. In morning, it is like there's a ptosis and there's a shoulder weakness. And after doing exercise and as the day will progress, the person will start feeling relatively more fresh and the performance of the person will improve. So decremental response for myasthenia gravis and incremental response is seen after making the person do some light exercise in Lambert-Eaton syndrome. That's the main difference that I want you to understand for this. And therefore, it is important that we also study the antibody here, which is involved. The name of the antibody is anti-P by Q antibody. This is acting against that voltage sensitive calcium channels, which help in release of acetylcholine at the neuromuscular junction. If this is the representation of the terminal end of any nerve, we have calcium channels which are present at these are the receptors you can see for acetylcholine, and the calcium channels are the one through which ultimately, I mean, there would be quanta of acetylcholine. That is why when the calcium channels will open, then acetylcholine release will be occurring here. So these are the molecules of acetylcholine. They are lesser in patients of Lambert-Eaton syndrome. Receptors are performing fine. If you upgrade the amount of acetylcholine at the NMJ, then the performance of these patients will definitely increase. Whereas in Lambert-Eaton, in comparison to myasthenia gravis will have blocked receptors. Coming to the treatment of these patients, the drug of choice for this condition would be answered as 3,4-diaminopyridine. This will increase the amount of acetylcholine at the neuromuscular junction. This drug basically acts on potassium channels. It's a potassium channel blocker. It increases the amount of acetylcholine at the neuromuscular junction. Along with this, we can add to the treatment part pyridostigmine. The advantage of pyridostigmine will be that it will inhibit the degradation of the released acetylcholine. So the treatment part is diaminopyridine enhances acetylcholine production, and pyridostigmine inhibits the breakdown of acetylcholine so that you can achieve symptomatic improvement in the patient, and workup for lung cancer in male patient would be done. To the end of this topic, I want you to be clear about this term by the name of neurasthenia, which you might encounter in couple of questions, and the symptoms that are described by neurasthenia patient might be same as that of myasthenia gravis. So it will be easy fatigability, tiredness occurring in a patient, but there is no organic cause in this case. Symptoms will be identical. There is a myasthenic fatigue, but there is no organic basis in this case, and the testing of the patient will be normal. And history of this patient will keep on changing. Like sometimes patient will say I'm weak in the morning, sometimes weak in the afternoon, sometimes weak in the evening, and you will find discrepancy every time. Or the patient will just say this, I'll put it like this is a plain lazy person. He is or she is having symptoms that might look like that of myasthenia gravis, but then there's no organic basis behind development of the disease. You should also be clear regarding a prejunctional defect by the name of botulinism. Well, here there was a home delivery, and the grandmother had given honey to the baby. This would be a disaster because if the quality of the honey is bad, like this was a boy baby, home delivery occurring in village in India, honey was given, and the spores of botulinum will germinate in the GI tract and will produce the toxin. Therefore, the patient will develop paralysis. That would be a descending paralysis. Most patients of botulism would be a newborn babies who would be having bulbar palsy. The bulbar palsy would explain the aspiration of milk, inability to feed, or nasal regurgitation of feeds in this child, and they can also be diaphragmatic paralysis, which can be life threatening. The main treatment for botulism would be to give antitoxin for this patient. This is an unfortunate complication, and lots of time, even without a diagnosis, the child might actually die. Botulism I have mentioned because this is also a pre-junctional defect or a presynaptic defect. The amount of acetylcholine, the toxin, acts on the neuromuscular junction, and it reduces the amount of acetylcholine released at the neuromuscular junction. So I would say the common thing between Lambert-Eaton syndrome and botulinism is only the decrease of acetylcholine release, but the age of presentation and the allied features that I have mentioned are grossly different. So there's no reason why, I mean, the clinical profile will be so different that we will be able to identify the diseases easily. As a summary, for myasthenia gravis and LEMS, the following pointers should be kept in mind. Myasthenia gravis is mainly associated with thymus abnormalities. Lambert-Eaton syndrome could be associated with small cell lung cancer, especially with male patients. On the left hand side, acetylcholine release is perfectly normal. The problem is with the receptors, so we call it a post-junctional effect or post-junctional defect. Left hand side, the release of acetylcholine is less. The receptors are perfectly normal, however. Left hand side, the antibodies which are involved are multiple, but the key ones to be remembered is anti-acetylcholine receptor blocking antibody and anti-MuSK. The third that you can remember, though I'm not writing it here, is anti-LRP4 antibody. Right hand side, the name of the antibody is anti-P/Q. This antibody acts on calcium channels, which will help in release of acetylcholine at the neuromuscular junction. So antibody P/Q is, it's again voltage gated calcium channels. There's a possibility that gender might be given same in both of them. Both of the patients might be having ptosis, extraocular muscle weakness contributing to diplopia, chewing muscle weakness in a patient. But now the similarity will end. The differences have to be picked up in the question. Left hand side, let me say he begins by saying a female, but he will straight away start from ptosis diplopia. He will not talk about proximal muscle weakness. Shoulder girdle weakness is mainly a feature associated with Lambert-Eaton syndrome, or difficulty in climbing stairs is a feature mainly seen with Lambert-Eaton syndrome. Another difference to be kept is reflexes. Reflexes are always normal or preserved in myasthenia gravis, and reflexes are reduced with respect to Lambert-Eaton. Then autonomic symptoms could be described in the question, like if it is a male, it could mention impotence, or in female frigidity, and then dry mouth, or maybe even orthostatic hypotension can be described in the question. By reading the language of the question, even if gender is given to be identical, you should still be able to identify. The next point is the clinching point of the question. If he mentions the word decremental by himself for repetitive nerve stimulation and incremental response on the right hand side, your job is done anyway, and you can identify the diagnosis in the patient. I want to clarify before you the fact that anti-acetylcholine receptor blocking antibody, if it is negative, that does not rule out the possibility of the disease. The disease could still be present in a patient. So it is okay for screening, but to confirm, you always need to go in for not repetitive nerve stimulation. It is single fiber electromyography, which is the confirmatory test for diagnosis of this patient. For the left hand side, the drug of choice should be answered as pyridostigmine, followed by thymectomy if it is generalized myasthenia gravis, or we will have to go for immunosuppression. So usage of steroids is valid for left hand side, but in Lambert-Eaton syndrome we are not using steroids. We are rather using 3,4-diaminopyridine. Pyridostigmine can be used even on the right hand side, because all pyridostigmine does is inhibit the enzyme responsible for breakdown of acetylcholine, so the muscles get stimulated for longer duration. In both of these cases, I want acetylcholine to act relatively few milliseconds longer. So the main difference between the two is not with respect to pyridostigmine, it is steroids versus 3,4-diaminopyridine. The surgical treatment for myasthenia gravis is thymectomy in majority of cases, and in Lambert-Eaton syndrome, because of association with small cell cancer in male patients, we will have to go in for a chemotherapy for small cell, because it can metastasize very fast. So we need to straight away give chemotherapy containing drugs like cisplatin and irinotecan for the patient. So these are the details that I would like you to remember for the disorders of the neuromuscular junction, and the comparison part is the main crux of the discussion. Attempt MCQs on the same, and you will have a better orientation for understanding these diseases. Thank you so much for your patience and hearing me out.